Assalamu alaikum, students. So this is part 2 of the glomerular filtration rate lectures, and in this we will be looking at basically one concept, which is the concept of clearance, and we'll be applying this concept to calculate GFR, renal plasma flow, and renal blood flow. For a quick clarification, a renal blood flow basically is a simple calculation. It involves hematocrit, which is known. However, it involves renal plasma flow. Obviously, blood has plasma, and it is the plasma that is acted upon by the nephron to extract GFR and other interactions with the tubular fluid. So the estimation of renal plasma flow is the tricky part. When renal plasma flow is calculated, then together with hematocrit, renal blood flow is a straightforward calculation. Okay, so we'll be using once again the concept of clearance with to estimate these three very important features of the nephron. So here we go. So basically, you must have heard fixed principle. You did this in circulation to estimate cardiac output. And very simply put, it is a simple principle. It has application, a wide application in medicine, in CVS, in renal physiology. Basically, what it means is, say, if you have an organ, let's say a simple organ, which has one artery, which brings blood to it, and one vein which drains the blood, takes away the venous blood. Okay, so fixed principle says that if blood is carrying something, a compound or a substance, which is not metabolized by the organ, then you can reliably predict the passage of this substance from the feeding artery or feeding vessel into the organ, and then through the organ into the exiting vein. Okay, and they will be constant. So the input will equal the output, because mass in this strict sense is conserved. It doesn't go anywhere. So what the mass of the substance which is coming in has to be equal to the mass of the substance going out. Now it is this principle that we apply in the concept of clearance. Simply put, clearance is basically stuff which is cleared in the plasma or filtered or cleansed from the plasma by the nephron. More on that later. So basically, this input-output business of the fixed principle, when applied to kidney, presents just one little addition. Because look, uh, basically, the input of the kidney is the renal artery, whatever it brings, right down to the level of the afferent arteriole, where it then just is dumped into the glomerulus and filtration takes place and all that stuff. And then renal, the efferent comes out and takes the rest of the plasma away. Okay, so this is that input. Okay, so kidney has one input. This is that. However, the output is not just renal vein. We know this. The output is also urine formation. So the blood that comes in to the kidney comes in via one source, the renal artery. However, the fate of the blood, what happens then to the blood, is twofold. Majority of the blood comes out, goes through and through the kidney, and comes out via the renal vein. However, the filtration fraction, which I have described in detail in the previous lecture, is filtered out. And while most of it is reabsorbed back, and hence reflects in the amount of fluid that is coming out in the renal vein, a fraction of it, a small fraction of it, normally becomes urine. So for the output part of this principle, when it applies to kidney, you have to take into account both the renal vein and urine formation. Okay, so this is just a modification of when you apply this principle on the kidney. Uh, so when we apply this whole concept to clearance and then apply clearance to estimate GFR and renal plasma flow, basically what we are saying is if we were to quote unquote uh, tag or or use a, let's, I'm using this highlighter, yeah, you see this highlighter, this red dot. What if somehow I could use this highlighter and highlight the blood that is coming through the renal artery into the kidney? Okay, so this highlighted blood will go into the kidney. 20% will be filtered out. Remember, it's highlighted, so it's like emitting a light. This is, of course, hypothetical. And that 20% will get filtered and enter the tubular fluid, while the 80% will escape from this whole thing, come to the peritubular network and off to the renal vein. Okay, so when the stuff comes out, either through urine or through the vein, if you were to add both of them, this should include the tagged blood that you sent in via the renal artery. Okay, so said in a slightly different terms now, explicitly mentioning clearance, is that when you sent in this tagged blood, it got cleansed, or filtration acted upon it and released some of this tag material during filtration, and that became part of the renal fluid, while the rest, i.e., the 80%, simply swept away. It's the 20% that got filtered out is what eventually became available for urine formation. So this is obviously just an example to explain it to you. If you use a substance, you inject in the body a substance which comes into the renal artery and then goes into the kidney, and then that substance gets filtered out and nothing else happens to it, and it becomes it comes in the urine and out it goes. So according to Fick's principle, you can calculate GFR, because this substance came in, you know that value, and it came out via one of the two exits. So the law of mass conservation says that the stuff that came in and the stuff that came out can reliably be measured. And in this case, we have very cleverly used this phenomena to have an estimation of the filtration potential of the kidney, i.e., the GFR. Don't worry if you don't understand it at this point. I'm just introducing the subject. We'll go into detail in a bit. So the purpose of this slide is to just introduce to you what fixed principle is and how we manipulate it in the concept of clearance to estimate GFR and renal plasma flow. And as I said, once you've done this, this is the major weight, heavy lifting. The renal blood flow is a very straightforward formula. Okay, so what is clearance? Clearance is, well, quite literally, a volume of plasma that is cleared of a substance, any substance, by the kidney per unit time. So the underlying thing is important. Volume of plasma. So it will include some sort of a volume unit, ml or liter or something similar. And then it is a per unit time phenomena. So it's amount of plasma that is being acted upon by the kidney per unit time to extract a substance, any substance, and make it part of the tubular fluid. Okay, this is very simply put, this is clearance. You clear the plasma, you liberate the substance from the plasma and make it part of the tubular fluid. This is the concept of clearance. This is the formula of clearance. It's denoted by capital C. So in this case, we are saying, let's say a substance X tagged along in the plasma of the renal blood. It came in. We know the amount of the substance X that we injected in this person. So if you want to calculate how much the kidney extracted from it, cleared the plasma of this substance X, you will simply use this formula, and I'll just walk you through it. Ux basically means the concentration of this substance X in urine, which is of course measurable. You can just take a sample of urine and measure how much substance X is contained in it, multiplied by the rate of urine formation. In a normal person at rest, it is generally around 1 ml per minute. So that is also known. You multiply these, you get a value over the plasma concentration of this substance X. So all of this is known. You get a whatever value that you get. We will look at this example in a bit. So whatever value do you get here is basically the clearance clearance rate clearance of that substance from the plasma. Okay, so let's take an example. So let's say this substance X, basically it has a urine concentration of 100 ml, 100 milligram per ml. Urine flow, as I said, is 1 ml per minute. Uh, then you have excretion rate, which is uh, it's basically when you multiply the amount of this substance in the urine, which is 100 into the rate of urine formation, which is 1 ml, you just simply get 100 milligram per minute. But now you get a rate. So it's very important that you concentrate on the units here. They become tricky as you go through certain scenarios that may come in MCQs and SEQs. And the plasma concentration, let's say, is 1 milligram per ml. So when you put all of this in this formula, which is right given here, so clearance of substance X comes out to be 100 ml per minute. So each minute the plasma is being cleared of substance X. 100 ml of substance X is being cleared of the plasma in every minute. Okay, so as you can see, this is purely a filtration statistic. It shows you how well your kidney is filtering a substance. Okay, we move on. Now, clearance can be used to estimate not just filtration, but also renal plasma flow. Renal plasma flow is a bit tricky. We will do GFR first, and let's see how it goes. So when we have already used the equation of clearance to estimate the clearance of substance X. This can be used to estimate GFR if that substance is called inulin. Now, inulin is a substance which has certain properties. Conceptually, if I briefly uh, uh, overview the qualities of a substance, ideal substance, which can be used in GFR estimation, from the top of your head, what do you think that number one quality of that substance should be, keeping in view Fick's principle? If you are thinking along the line that it should not be metabolized or produced in the kidney, it should be just whatever is coming from the renal artery. It should not be uh, adulterated by the kidney tissue in any chemical way. Then you're right. So this substance, and inulin is that substance. It does not get uh, altered by the kidney. Whatever comes in from the renal artery, that is filtered out nicely, and no questions asked. Another aspect is inulin is filtered only. It does not get reabsorbed and it does not get secreted. So literally, the amount of inulin that you give, it's filtered out, and whatever is coming in the urine is only what is filtered. The nephron doesn't deal in any other phenomena, reabsorption or secretion for inulin. So you can reliably look at the urine, you know the rate of urine, you know the plasma concentration, you can easily derive the clearance of inulin, and it will reflect the amount of glomerular filtrate that you are forming per minute. Uh, it's in another way, you can say that you have tagged, you have sort of colored, quote unquote, colored the plasma with inulin, and when this colored plasma got filtered out at the glomerulus, that whole filtration reflects accurately the amount of plasma that also got tagged along, if you now understand what I'm saying. So why inulin? And let me just go to the next slide where I document this, why inulin is an ideal substance. Don't be bothered about this for the moment. Just look at the left side, the blue box of this slide. Inulin is not produced in the body. It's actually a fructose polymer. You get it from a pharmacy. You inject it in the person according to a specific protocol. It's the ideal substance for GFR estimation because it is freely filterable at the glomeruli. As I said, it's not reabsorbed or secreted. It is not metabolized by any other organ of the body. It is just filtered at the nephron. So you can be rest assured that whatever you gave to the patient, it will only be touched upon by the nephron, and even in the nephron, it will only be filtered. It won't be, there will be no other thing occurring on this substance, even in the nephron. It's not toxic, and it does not alter GFR in any way, which can give you a false elevated value of the GFR, or false lower value of the GFR. So it doesn't alter the GFR itself. So that's that. However, we will see in the next slides that in any case, inulin is an exogenous agent which you introduce in the body, and in any case, the rare person who may be allergic to this reaction may react to it, and there will be another issue, the antigen antibody reaction in the body. So the immune reaction of the body will make this simple procedure very tedious, and in that particular person, this might not be ideal. Also, in patients who already have an infection going on, in injecting them, it in itself is a risk, because you are using a needle, and the puncture site is basically an opening in the skin through which further viruses and bacteria can enter the body. So again, in those compromised patients, even a simple procedure as this can be an issue, as we'll see later on. Going back to the previous slide. So we have comfortably looked at how clearance of inulin will reliably, very reliably reflect the GFR in humans. Now look at renal plasma flow estimation. Now, imagine for a moment, put this slide aside, just imagine now. Imagine a bus, a bus on wheels. It's moving. It's moving from one place to another. This bus has 100 seats, okay? And it's auto-driven. It's like a Google auto-driven satellite navigated bus, all right? It has 100 seats. Now, it goes from its initial station, station 1, to station 2, okay? At station 2, 20 passengers get off, okay? They get off, and they go inside station 2 and off to their journey. So the bus now resumes its journey from station 2 to station 3. And at station 3, all the rest of the 80 passengers get off. Now, the perceptive students would be grinning at this moment, because this is just an example of how renal plasma flow flows through the system. So if you remember filtration fraction, we mentioned that when plasma comes in the glomeruli, how much of it is filtered out? 20%. So you can, just for imagination's sake, you can imagine 20 units of plasma getting off, quote unquote, this station, the glomerulus, and becoming tubular fluid. What happens to the 80? The 80 units of plasma, they flow out of the efferent and via the peritubular capillary network, eventually they find themselves in the renal vein and off into the systemic circulation. So renal plasma flow presents a challenge. Why? To estimate renal plasma flow, you cannot use, say, inulin. Why can't you use inulin? Well, the straightforward answer to that is inulin is only filterable, as we just studied. It's only filterable. It doesn't do anything else. So it will account for the 20 passengers, the 20 units of plasma that get filtered out normally. But what about the rest of the 80%? Now we are not interested in GFR. We are actually interested in renal plasma flow. So we're not just interested in the renal plasma flow that gets filtered out. We are interested in that, but we are also interested in the 80% that escapes the efferent and then so on and so forth. We want to understand what is the total amount of renal plasma flow that is flowing into this system. So what do we do? Well, the ingenious thing to do is to look for a compound which has a very high extraction ratio, meaning that it not only gets filtered freely at the glomerulus, giving you the picture of the filtration, it also gets secreted heavily from the peritubular network into the tubular fluid. So it is filtered and it is secreted. And I've already told you what secreted means in the nephron. So PAH, para-aminohippuric acid, is one such compound. When injected, it gets filtered and secreted to such an extent that even in one single circulation through the kidney, 90% of PAH is cleared. Again, the word from clearance, it's cleared from the plasma. So if it's cleared from the plasma, it then enters into the tubular fluid and you can now easily measure it in the urine. The points of saying this is the amount of PAH which is coming in the plasma in the urine will reflect both PAH, the one that got filtered and the one that got secreted. So between these two, it will give you a pretty accurate picture of the plasma that totally entered into the afferent arteriole, gave the 20% at the filtration, and then the rest of the 80% while passing through the peritubular network heavily secreted PAH into the tubular fluid, giving you an idea of how much equivalent plasma came in the peritubular network. Okay, this is called extraction ratio. It's 0.9 or 90%, very high extraction ratio. So this is that. Now there are two let me just first give you the clearance. Let's get this out of the way. So the formula now, according to Fick's principle, is the amount of pH in the plasma, renal plasma flow, should equal the amount of pH in the renal vein and the renal plasma flow plus whatever is happening, whatever is going on in the urine. This is the Fick's principle equation. You solve it for renal plasma flow, you get the classical clearance equation where you have renal plasma flow here, and it's basically a clearance of PAH in essence. You have the urine depicted above, and slight change is that you have renal arterial PAH minus renal vein pH. Okay, this is the real renal plasma flow. And this is where the slight complexity, the trickiness that I have been saying regarding renal plasma flow resides. There is a actual renal plasma flow and there is an effective renal plasma flow. Before I explain it here, let me just explain it in words so that you can have an you can have a concept about it. So the total blood that comes in, the total amount of plasma that comes in the tissue goes everywhere in the kidney, doesn't it? The kidney just isn't comprised of nephrons. It has its own parenchyma. It has its own tissue. It has its own adipose tissue and connective tissue, right? Plasma also goes to those areas. It just doesn't go to the nephron. So if you want to say it in a sentence, the total blood, including the plasma, they go to the nephrons, yes, and take part in filtration and all secretion and all that, urine formation, etc., etc. And they also supply the tissue of the kidneys, namely the connective tissue and the adipose tissue. So who will calculate that fraction of renal plasma flow? Well, you can't, because you are focused on the nephron. That is where the difference is. When you say simple renal plasma flow or uh, actual renal plasma flow, you basically are saying everything. You are saying the stuff that is appearing in the kidney, which got filtered and secreted, and the difference between artery pH and vein pH. Because obviously, and very important to note here, the blood carrying the plasma, which goes to the connective tissue and the adipose tissue, will have veins coming out, which will have pH. Okay, and the adipose tissue and the connective tissue have no business with pH, so they won't touch it. So the renal vein will carry some PAH, which basically is coming from these tissues. Would you expect blood coming from the peritubular network to have any pH? Unlikely, because of the high extraction ratio. So the pH that goes into the nephron almost entirely becomes a part of the urine due to high extraction ratio, which I have explained. However, the blood that goes to the connective and the adipose tissue, that is the blood through which, when the venous blood gets generated, it will have some traces of PAH and it will be small. So the actual renal plasma flow, you cannot ignore the venous PAH. Okay, now, and here comes the kicker. It's extremely difficult from sampling and logistical point of view to sample renal artery and renal vein. As you can imagine, these are retroperitoneal structures. And then on top of it, you're not talking about the kidney, you're actually talking about the small artery that is going in and the small vein that is going in. And of course, sampling it, it's such a high pressure. It's almost nearly impossible. Certainly impractical to do, definitely impractical to do on routine basis. Okay, so what do? You basically generate this value, the plasma pH value, by sampling any peripheral artery. And the assumption, safe assumption, I would say, and is reflected in the literature as well, that the safe assumption is whatever pH is running around in the systemic arteries is almost the same which enters into renal artery and hence enters into the renal tissue. Uh, so that's one thing. Okay. Uh, but what will happen with the renal vein? The sampling issue and all that sort of stuff. So basically, for that, we coin another term: effective renal plasma flow. Effective renal plasma flow basically means, effective means as far as the kidney filtration, the nephron is concerned. So effective renal plasma flow is basically the blood flow, the plasma flow, which goes to the nephron. So that you can ignore. You see that there is no venous pH here, because here the extraction ratio is so high that peritubular veins do not have uh, maybe a minute amount of pH which you can easily neglect. So this here you can only have, you may only have the plasma pH, just like a simple clearance formula. So effective renal plasma flow can be derived by running a simple equation, clearance equation of pH, and you will get effective renal plasma flow. Would it be the same as actual renal plasma flow? No. So the effective renal plasma flow approximately underestimates by a factor of 10% of the actual renal plasma flow. Said another way, actual renal plasma flow is 10% more than effective renal plasma flow. I hope you got that. Do read the, I have given it in the, I've actually uploaded in your Facebook, the exact reference of the chapter of Guyton, where he talks about these issues. I'm not very sure, maybe the new edition of Guyton talks about the actual and effective renal blood flow and makes a differentiation. Probably the old editions, probably they didn't. But anyway, this is in Ganong and other books, they make this differentiation. Remember the 10% difference. Okay, so this is actual and this is effective. As you can see, there's a difference. So you now know why there is a difference in there. Okay, so uh, uh, basically on a routine basis, you are working in a renal unit, you get 60 to 100 patients and you have to run GFRs in all of them, putting insulin in these people, inulin, I beg your pardon, in these people, and waiting for it to equilibrate throughout the system. There's a whole protocol in injecting in, then waiting for it to equilibrate, and then getting timed urine samples. It's a tedious process and it requires time. If you are working in a public sector hospital where you are getting loads and loads of patients from the province, this is impossible. Plus, inulin obviously will incur a cost to the patient, and the non-affording people would not be able to afford that. And time-wise, you won't be able to afford running inulin clearances on your patients as a routine. So while GFR exact estimation in critical patients should be done by inulin, routine GFR estimations can be done by looking at their plasma creatinine. Now, creatinine, interestingly, is normally produced in the body. It is produced by muscle breakdown, as you may know from your biochemistry. So, plasma creatinine is steady depending on the person's muscle metabolism. And plasma creatinine GFR estimation reflects to a good efficient extent the actual GFR. However, as every good story has a twist, this story has two twists. Creatinine, if I tell you that creatinine gets secreted a bit in the renal fluid, what would you say to that? Well, you should say that it is not an ideal substance then, is it? Because an ideal substance is not reabsorbed nor secreted. Correct. That is inulin. But we already said that, okay, we can't, if we can't afford inulin, we have to make do with creatinine. So it is secreted. That's a problem. However, as irony would have it, the plasma estimation of creatinine is on the higher side as well. Okay, so plasma creatinine is not very accurately measured because creatinine resembles some other compounds in the blood normally found. So when you write up a test for plasma creatinine, you have a value which is creatinine plus those substances which are like creatinine. So the test is not sensitive enough to decipher your creatinine from those creatinine-like substances. So it reads those substances as creatinine as well, resulting in a slightly elevated, falsely elevated amount plasma concentration of creatinine. Okay. Now, if you can imagine, put this in the clearance equation. So the amount of creatinine which is coming in the urine has the secreted creatinine, so it will be elevated. The U multiplied by V for creatinine will be elevated falsely, but as will the plasma also will be elevated. These two cancel out each other, resulting in very inappropriately accurate uh, figure of GFR. So the plasma creatinine is a good index of GFR. Here you just look at this diagram. It's a good diagram. He has decreased GFR by 50%, and look at the creatinine. As soon as he dropped it by 50%, creatinine starts to go up, because obviously it's not being filtered because you have dropped the GFR. And here, as soon as you dropped the creatinine, its excretion dipped down, because excretion is equal to GFR. It's approximately proportional to the multiplication factor of GFR into plasma amount of that substance. In this case, it's creatinine. So as soon as at this point you drop the GFR to 50%, the excretion plummeted significantly straight down. But at this point, then later on, uh, when creatinine started to creep up in plasma, okay, it started to creep up in plasma, even at a lower 50% reduction in GFR, since you have this multiplication going on here, this would start increasing because of the decreased GFR. Okay, so GFR, while it's decreased, initially this would be constant, or it will be around constant. But as soon as you hit 50% decrease in GFR, the concentration of creatinine starts going up. This starts going up. So eventually, the excretion would plummet, and then gradually it will improve because of the high plasma creatinine that is being dumped into the plasma, and that will cause increased amount of creatinine being filtered at the glomerulus, which will start increasing in concentration in the tubular fluid, and hence getting rid in urine. Okay. The takeaway message is basically, for practical purposes, plasma creatinine concentration clearance is gives you a good value of GFR, and even a shorter version is just looking at plasma creatinine gives you a good view of GFR. These two graphs are evidence of that. Whatever GFR decrease you have a corresponding increase in creatinine. So when you are practiced enough in this, you just look at the creatinine concentration and you extrapolate whatever fluctuation in GFR would be in your patient. Okay, then the rest is, as they say, chemistry. Renal blood flow is basically renal plasma flow oblique 1 minus hematocrit, hematocrit being 45%. And this is easy peasy, not a problem. Renal blood flow gets calculated and everybody is happy. The references for these books are these. So this basically finishes our GFR, and inshallah, next week we'll start discussing the next in line topic, which I believe is micturition. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.